4, 3, 2, 1. We are live now.
Good evening, hello, and warm welcome to the 47th session of Pediatric Orthopedic Active Learning Sessions. The aim of these sessions is to expand the horizon of our fellows by exposing them to the world authority on the subject. It's our pleasure to have Dr. Jill Flanagan with us today. She did her undergraduate schooling from George Washington University of Medicine and Health Sciences. She had orthopedic training from the same institute. She did her fellowship in pediatric orthopedics from Children's Hospital of Atlanta. And after that, she became a consultant at the same institute. She has a special interest in osteogenesis imperfecta. In addition to that, her special interest is in limb difference, deformity correction, and also limb lengthening. Today, she is going to speak on a very important topic on the evolution of treatment of OI. From classification and the management, the treatment has changed a lot in last 2 or 3 decades. And she's going to tell us about why this treatment has changed. We know that genetics has played a very important role in that. But we would also like to understand what are the other factors which is responsible for this change in the management. So with that short introduction, now I request Dr. Jill to take over. Over to you. Thank you.
Thank you. So again, thank you for this invitation for me to talk about one of my favorite orthopedic conditions to talk about. And I think for most of us, the more you know about something, the more questions you have. And so you're going to see from this talk, I don't have a lot of answers. I have actually more questions, and hopefully we can work collaboratively to try to understand some of these issues that are facing us now. So that being said, let's talk a little bit about OI. And so the Sillence, it's not forwarding. Sorry about that. Now I should be able to see it. So the Sillence classification came out in 1979, which is crazy that it was almost 50 years ago. And at that time, Sillence grouped OI into 4 different OI types, mostly based on inheritance as well as the phenotypic look. So you had the group 1s, 2s, 3s, and 4s, and it didn't go by the severity, because we know that the group 2s or the type 2s are the ones that he called lethal, and the 3s are severe and 4 are moderate, and then the 1 is the one that's supposed to be the most mild. And now if you fast forward, we have, at least as of 2020, over 18 different subtypes, and not all of them are collagen 1 mutations. And where we're really changing our treatment is really understanding what the genetic mutation is. Because, for instance, with OI type 5, and I'm going to show you a picture of that, they act very differently, mostly because when they fracture, when we do surgery on them, they have this really extreme hypertrophic callus response that we still don't quite know what to do with. And then there's other mutations down the chain. For instance, in the WNT1, which is OI15, they have a much higher risk of non-union just because of the way that it affects the bone healing cascade. So let me move. Sorry, it's a little tricky. So here is just what that type 5 OI looks like. This is the IFIT-M5 mutation, where you're really seeing that hypertrophic callus, especially where the problems are is in the distal humerus. If they get a callus there, sometimes you can get restrictions in elbow range of motion. And then obviously you can see calluses such as the one in picture C, where there's such an incredible response, it's hard to know what to do with them. Then back to this Sillence article. So the group 2s or the type 2s, he called these were perinatally lethal. And you have these accordion type femurs. And I would say our job, especially as orthopedic surgeons, is to really teach people that it's a lot different now than it was then. For instance, these are 2 of my patients. They were both born in 2021. They're twins. And as you can see here, have x-rays just like that Sillence article. So these are type 2 twins. And it took a lot of effort in our hospital to make sure that they were being treated appropriately. And what I can show you now is here they are at age 2 on just bisphosphonates. And physical therapy and occupational therapy. And then this is what they look like now at age 3. And I can tell you that twin A has rods in her femur and her tibia, and they actually both have rods in either of their arms as well. For those of you on social media, I am not, but apparently they have over 1 million followers here in the United States, I think, because they're the cutest little twins ever. And so now what we can say is that with advances in our treatments, that the type 2s are not always lethal with very specific treatments, and it really comes down to the care in the neonatal intensive care unit. We can get their breathing under good control when they're younger, and they can survive that first hit. They can do really, really well. These are very happy, active young girls. They can sit, they can play, they can talk, they're intelligent. So it's been a real gift to be able to watch them. And so, and now because they're over 3 years old, we designate them as type 3 rather than type 2 because they have survived. And then in the type 3s, these are more of our severe kids. So here's an x-ray of one of my patients that has type 3 OI. And in his classification, his article, he said that there was a very high mortality rate, both in infancy as well as in age 30 to 40. And now I can tell you that this is how kids look, at least the way that I see it. So fractures at birth, and then usually that multidisciplinary approach when they're younger, which involves physical therapy, occupational therapy, bisphosphonates for sure. And then usually in my hands, the roddings are done between 18 and 24 months of age. And I think they can do really, really well. Most of them are household ambulators, still usually using wheelchairs for some for longer distances, but not everybody. And so here's, for instance, 2 of my patients, both with type 3 OI. And so you can see this kid on the left. We have a OI camp here in Atlanta that I started about 3 years ago, which is, we have no fractures so far in camp, so it's a lot of fun. But this is one of my kids teaching us how to do yoga. And then the other picture on the right is actually the x-rays I showed you on the previous slide. This is him at age 10 climbing the rock wall for his birthday. And so his mom was so proud, so she sent me this picture. So these are not kids that are dying in infancy. They can live very fruitful lives. And so the prognosis has really changed for these children compared to what things were like in 1979. And so now with our multimodal, multidisciplinary care, we can improve their function, we can improve their quality of life, and they now have near normal life expectancy, which is giving us a different problem, which we're going to talk about, and how do we treat all these adults with severe OI? And at least in the United States, that's a really big problem. I'm proud that it's a big problem because they're living and they're thriving, but they can still have different adult problems. So, so again, that's just a little purview of how far we've come just by looking at things phenotypically. But just to take a step back into what OI is, so most of you know that in general, it's a type 1 collagen mutation. I gave that whole long slide showing 18 different types of all these different mutations, but still the vast majority are type 1 collagen mutations. Clinically, they're characterized by having these skeletal fragilities and deformities, but the type 1 collagen is ubiquitous and it affects every single organ system. And because of that, it took a long time in Atlanta for us to have a multidisciplinary clinic. And I would say if you had any of those resources in your country, I would urge you to try to do that, because it really does make a big difference in their total care, because it is not just about their bones. Type 1 collagen, if you remember, there's 2 alpha-1 chains coming from collagen 1A1, and there's 1 alpha-2 chain coming from collagen 1A2, and then they mold together to form this collagen triple helix. And then this slide, to me, helps me understand what's really going on at a molecular level with OI. If you remember from way back in the day, at least for me, and probably for a lot of you back in chemistry, glycine is the smallest amino acid there is. And so when we're forming this triple helix, the glycine repeats every third amino acid, so it aligns in the center that you're seeing here to help form that triple helix. And so interestingly, and it makes sense, most OI mutations are glycine substitutions. And so rather than having the smaller glycine, you get a bigger amino acid in its place, and so it can't form this triple helix as well. And in some of the more mild OIs, we tend to just see a little bit less collagen, but in these, especially these more severes, this triple helix cannot form, and it is what causes their bones obviously to become abnormal as the rest of their, as well as the other organs. This is more my slide. This is the way I think about OI with the drawing tools that I have in PowerPoint. So here's a normal bone. You have your regular collagen, you have your mineral, and it's organized in a really consistent pattern throughout. And then when we think about normal bone compared to OI, if the moderate type mild type compared to severe, this is what it looks like to me in my mind. And then how it translates on x-rays is this. So these are all children that are 2 years old, right femur, and you're seeing the one on the left that has a normal bone. The one on the right, that girl has type 4 OI. And then the one all the way on the right has type 3 OI, obviously who has a fracture despite being on bisphosphonates. And so that's really the differences of just what this bone looks like radiographically with their genetics. And then as far as treatments go, I've already alluded to it. I'm a really big fan of multidisciplinary teams. The ones on the left, so ortho, endo, pulmonary, dental, audiology, that's the core team that we have in Atlanta, along with physical therapy and occupational therapy. I would say my dream would be to have all the other ones on the right. So pain is a really big problem with OI. And I'm going to talk a little bit about that in a few minutes. Psychology for both the kids as well as for the adults. There's a large fear of falling. There's challenges with having a chronic disease, and how do those children face being kids with this kind of a problem. GI is big because a lot of them will have severe constipation. We'll talk more about that when I talk about acetabular protrusio. Many of them do have hearing issues, so not only getting their hearing screened, but making sure that there's somebody that can treat it. And then genetics can certainly play a role just to help with the diagnosis if needed. Our treatments are obviously surgical, just to help prevent fractures and correct deformities and prevent deformities from occurring. The medications are certainly improving. The group out of Montreal described using bisphosphonates back in 1998. And really, that was the landmark study, which has revolutionized our care in OI. I would say as surgeons, we certainly have egos to say we're fixing these bones and making them better, but it's really the combination of the therapies, the medications, and the surgeries, along with some of my other colleagues, that are really helping these kids out long term. Physical therapy as well as occupational therapy can make huge differences for them. And then we still need to make sure they have some durable medical equipment, whether they're little arch supports for their flat feet, shoe lifts, as this child here needs for his obvious leg length difference, spine braces sometimes we'll use, and obviously wheelchairs, walkers, all those things to assist with them to be mobile. So right now, in the first half, I said, these are all the great things we do for OI. We're doing so much better than before. Yay, we're happy. Kids are happier, healthier. They're living longer into being adults. So what are our problems? What are the current orthopedic challenges in OI management? And there's really the top 5 that I think of. Sorry, we're going to talk, but before I'm going to talk to you about what I think, one of the things that I did along with a couple of my surgeon colleagues here in the States is we asked patients and families, well, what do you want us to look at? Like, we think we should be looking at non-unions, for example. So I'm going to talk about that. But what do the patients want us to look at? So we did this study. This was right in the middle of COVID, saying, hey, what do you want us surgeons to review? We're certainly interested in trying to make your lives better. And so we sent out this survey with the help of the OI Foundation here in the United States. And I think we believe we had over 340 responses to this survey, really asking questions about surgery, access to health, pain management, and mental health. And it was quite a humbling response, and I'm going to show you what they said. And so when we asked them, what do you want us to focus on? It had nothing to do with our surgeries. They asked us to help manage their fracture pain. They wanted us to do better at managing their bone pain. And they wanted us to help them with their mental health of decreasing anxiety around fractures. And they actually had a lot of concerns also about adults with OI as well. And so really, and I would say that these are projects that I'm working on with the OI Foundation and some of my colleagues. But again, they're fairly happy with how we're doing surgically, which is good. But again, we still really need to focus on the pain component, which nobody really has a great grasp on how to help with that. And as well as the mental health around having this chronic disease where you are fragile. So our orthopedic challenges in OI, a big problem, at least here in the United States, is who's going to manage OI adults. So at least here, like myself, we have our pediatric orthopedic surgeons, but then once these kids become adults, I'm not allowed to take care of them anymore. I still sneak some of them into my clinic, but we don't have as many comprehensive clinics here for adults. And a lot of our adult traumatology surgeons are more reluctant to operate on these patients. They don't know the names of the rods that we're putting in. Nobody knows how to do a hip replacement in someone with OI when they need one. So again, these are some of the problems we're having now that they're adults. And we're continuing to work on advocacy and trying to improve their care. Non-unions is a big problem. And so we're going to really touch on that. There's 4 bones that are highest risk for non-union, whether they break or surgically we break them. We're having difficulty healing, and I'll talk about some of the potential solutions there. How can we decrease the number of revisions? Again, as much as I love doing surgery, I'd rather the kids not be in surgery and obviously having fruitful childhood and a fruitful life. So what can we do to decrease the revisions? And really that goes down to some of the technical pearls of how we do the operation to begin with. And then I think some of the medical management. Acetabular protrusio is a really big problem, and I'm going to show you some extreme examples of it, but there are no good solutions that I know, whether it's prevention or treatment for this problem. And the last one, which I'm not going to talk as much about here, is scoliosis. Scoliosis is a big problem. There's some research that I'm working on trying to help with some of the treatments there, but these to me are the top 5 things that keep me up in wondering what can I do to make things better. And so we're going to go through some of these now. So we see non-unions in the humerus. A lot of these x-rays, by the way, are not mine. I'm not going to say whose they are. I'll let you know when they're mine, though, so I'll take the blame for some of these. But these are problems even in the best of care here in the States. You get humeral non-unions. We see femoral non-unions, especially there in that subtroch area. Tibial non-unions. That kid looks like mine. And then this one's definitely mine, forearm non-unions, although luckily we were able to fix him and get him healed. So let's talk about humeral non-unions. Why do you get them? So if you have these deformities that you're seeing here, you have very limited bone stock distally, and you're in an area that you have really great range of motion. And so really trying to get rigid fixation in a really small bone segment just tends to be a big problem. And then most of these kids are on bisphosphonate. So bisphosphonate is an anti-resorptive. So by definition, it's impairing the bone healing process. We know it's a great medicine to make bones stronger. There are definitely newer medicines that are up and coming, at least in the United States. I'm not as abreast about the medication approvals in India, but I'm certainly happy to look it up for you guys if you need to. So this is the problem with these humeri, is just a really bad problem in a really bad area that already has challenges healing. And so you see things like this, and then trying to make it even better, looks like this, and then the rod breaks, and then trying to make that better again, and then you end up in problems like this. And I would say this patient is treated by a very experienced OI surgeon. Again, these are just really, really challenging problems. And so trying to get a better handle on how to treat them better. If there's some improved techniques on this, I'm not going to touch into it. I'm happy to answer questions. Or maybe there's an alternative to a bisphosphonate, which I think there certainly are. But humeral non-unions are a really big challenge to us surgically. This one's one of my patients, so I thought I would at least throw myself out there under the bus. So here's one of my 21-year-olds. He recently had moved to the United States from Mexico. He had no prior OI treatment. He's in a wheelchair, and his only real complaint was this left humerus. If you look closely, you can see just how bowed his femur is on that bottom left corner of the screen, but he's not complaining about that. It's this left humerus. And so with me, at least what I told them, I said, all right, we'll consider trying to fix this, but before I do anything to that arm, we need to make sure that the rest of you is okay. So he had to be seen by his primary health doctor. So we had him to see a family medicine doctor. He needed a pulmonary evaluation, make sure his lungs were working well. We had his bone health optimized. We started bisphosphonates here, and I waited 8 months to take him to the OR. And I wanted to show you guys this picture here. So to orient you, that the big rubber thing, that's the radial nerve that's within the blue vessel loops. And then to the left of that, that's the humerus, the distal humerus, and that's a 1.6 millimeter K-wire in the distal humerus. So there's barely any canal, and you can see just how much bigger the nerve is than the bone. and to always implore you always find the radial nerve first before you go after these, because it's almost always within the middle of the deformity. So I thought that was a great picture just to show you guys just how big the nerve is and how small the bone is in relationship to it. And so it was a struggle, again, getting a canal. So this is a 4 millimeter rod that was in there. And you can even see at 6 weeks, the top screw is already coming out. The rod migrated up, and I was praying that he would heal. And at 3 months, nothing else has shifted or moved. And if I zoomed in closer, you'd see that he actually so far has healed quite nicely. Hopefully he doesn't follow up, so then I don't see a non-union or a refracture. But I would say so far our goals of improving his pain, he feels a lot better. His function is certainly a little bit better. And so hopefully he's doing okay for now. But again, humeral non-unions are a really big challenging problem. Femur non-unions, so almost always they're in the subtroch area. As you see here, a lot of them, even with the rods in, will tend to bend and break in this area. I would say anytime I'm doing a rod, even primarily our revision in OI, usually the first osteotomy is right at that subtroch level, so it's where they want to bend. Sometimes they're symptomatic from these bends, and sometimes they're not. This is not my patient, but from the story that I heard, I believe this patient was partially symptomatic, so they were planning on getting a revision done. And then they showed up to their pre-op appointment, and I don't know if you guys can see it, but this is a bad problem we see in OI as well, that they get these femoral neck fractures. And sometimes the femoral necks are symptomatic, and sometimes they're not. Those treatments can be challenging, especially in the setting of acetabular protrusio. But again, if you look for femoral necks, you'll see them. This one's pretty obvious, but there's some other ones that are more subtle, and I'll show you some pictures in further slides. The femoral neck fractures in OI are really characteristic, just how you see it and what to look for. Oftentimes we'll have to get CAT scans because it's really hard to see radiographically, except for this one. This is one of the worst I've ever seen. Here's one of my patients. So she has type 8 OI. And if you look closely, you can see the bilateral subtroch stress areas. And then she does have a femoral neck fracture on the right-hand side. She did not have any complaints of pain. And I had to tell them, by the way, you broke your hip at some point. I did not treat it at all surgically because she had no pain, and then she got better. But again, if you look for these femoral necks, they're going to be there. But these femur non-unions, in terms of how we treat them, I think it really goes down to the rod size as well as the medical management. I'm going to talk later in revisions that we don't really know the right size for the rods. We know if it's too big and too thick, that you're going to get osteolysis and the bone will disappear. But if you have the rod too thin, then the bone's going to bend. And with what the rod does, as you're seeing here, it tends to migrate out laterally, just as you're seeing the top of the rod here do. But again, don't have any solutions, but these are the problems that we see. Tibias are a big problem in terms of tibia non-union. So this is another one this is the kid that was doing yoga that I showed you in those pictures. This x-ray was when he was 6 years old. This is an asymptomatic non-union, even though you can see it there. He had no pain, no problems. I would say technically, I like the way the rod's put in. On that lateral view, I tried to get the rod as posterior as possible to try to help prevent procurvatum deformities from happening. So I would say technically, I think this looks pretty good. The rod size looks appropriate as well. To me, it doesn't look too big or too small. And you can see all of his bisphosphonate lines. So he's very appropriately treated on bisphosphonates as well. But sometimes they get these asymptomatic non-unions, or they get non-unions if they're asymptomatic, like this one is. We don't really, at least for me, I don't really do anything at all. But then 8 months later, which was 1.5 years post-op, now he is complaining of pain. And if you look closely at the x-ray, that non-union site looks bigger. But it wasn't really debilitating. And again, with the goals of trying to decrease the number of operations, our plan was just to wait. And then when we needed to do another surgery, we would just put a plate on this at that time, since the rod looks, to me, looks very appropriate. And this is a pretty sad story, but then what happened was just a few weeks later, he was at school and somebody stepped on his leg on purpose. And so he fractured above, bent the rod, and obviously made the non-union worse as well. And so in this particular case, I think obviously the time was to revise this. And so the plates are interesting. We're definitely starting to use more and more of them here. And we don't have all the right answers of what size plate, how many screws, do we take the plates out? And to answer some of those, to me, I don't love doing plates all the time. If I do, I try to keep the plates pretty small, because I still don't want to cause osteolysis to the bone. I just like the idea of more of this load sharing device like a nail compared to just the plate. So to me, 2 screws above, 2 screws below, just enough to try to get this to heal. And then when you take the plates out, the concern is that you fracture at a screw hole. So that's why, to me, I think small plates, small screws work a little bit better for what the goals are here. But usually if you add the plates, it'll provide a little bit more rotational control, but at the expense of stripping periosteum to put the plate on. And so to me, I don't think this is the best solution per se, but it's certainly a solution to think about. And it would have been great if I could put this plate on before he had refractured his leg. The epitome of tibia non-unions is this patient of mine. So she's 24. Phenotypically, she has type 4 OI, but I kind of wonder if she has one of these more rare types. It may not project well on this lateral, but I'm going to circle it to you. She has a non-union there, and she has pain right there, and you can see another non-union site there. And I did not do this initial surgery, but she, this is how she presented to me. So she was in a cast here because her leg was hurting, and you can see then what happened to the rod, fractured because of her non-union. And then she's a gift that keeps on giving. So while I was planning her revision surgery, she fell a week later and fractured her forearm. So we knew, at least for me, that there was no way this was going to heal. And to me, what I look at, especially in that forearm, if you look at that ulna, there's no canal. And this is, to me, very similar to congenital osteoarthritis of the tibia. When I think about that diagnosis, when there's no intramedullary canal, I just think that they lack capacity to heal. And our goal is to be able to create them a canal for the bone to heal. And I think even though the disease processes are very different, I think that same principle though holds true. And so for her, I think the goal was to fix both of them. So sometimes the idea is to get rid of a bigger rod and put in a smaller one so that you have more bone stock available. And that's exactly what I did for her. And even a year and a half later, she is still healed on her tibia, every single site. So that's a win. But her forearm, 2 revisions in, despite making the canal, and she's still minimally to moderate. The top osteotomy is healed enough where she doesn't have symptoms, but that distal one still needs some work to get that better. So definitely I don't have all the answers, but these are some of the bigger problems we have. And so looking at some of the literature on non-unions and delayed healing in OI, this is the big study that's quoted all the time. This comes from 2004, and this is the group up in Montreal looking at fractures compared to especially osteotomies and bisphosphonates, because I get a lot of questions of, should you give bisphosphonates at the time of surgery? How long do you hold them for? And what this study suggested was that nearly a fourth of their fractures and half of their osteotomies continue to show non-unions 1 year postoperatively. And so they suggested to hold bisphosphonates, especially around the time of surgery. Maybe with fractures, when you see some early signs of healing, that's when you can give the medications. And then when you looked a little bit closer in terms of what the risk factors were for delayed healing, to me, it made no sense. It was more the mobility score. And so, but to me, and again, I don't know what things are like in your country, but at least in Atlanta, access to care is what's really challenging. And so some of my patients live, even in the state of Georgia, in the United States, 4 or 5 hours away from me. And so they can't drive back to get their bisphosphonates. The other thing is too, surgically, with this study, this is still at the time when saws were being used to do osteotomies in some instances, large incisions, big open osteotomies, and we know all those are factors into the non-unions as well, and they didn't really address that in this study. I think even now, Dr. Hamdi is the surgeon that does most of the surgeries up in Montreal rather than Dr. Fassier. And he doesn't do his osteotomies like it was done back 20 years ago. So I think things have changed. And so if you have questions of when do I give bisphosphonates, do I hold them at the time of surgery? The answer is, at least for me, no, because I think the risk of not giving the medication is greater than the risk of non-union. And so oftentimes here, if I'm planning a surgery, we're trying to get their bisphosphonate right after surgery. And I really haven't, I should probably study it more. I still have a feeling that my healing numbers are better than the 50% that they're showing here, despite when the timing of the medications. So again, I probably hope I'm generating more questions for you than answers. So, so again, we talked about, well, what can we do to make things better? Are some of these non-unions iatrogenic? Again, are we giving them enough fixation? Are we using the right size rod? Should we be adding plates? Are the bisphosphonates causing some of these non-unions? And the answer to all those things is yes. And then we think about solutions. So I talked a little bit about supplemental plate fixation, and I think that's a great solution, especially for a symptomatic non-union where the rod looks good. I think in that case, adding a small plate, sending them home the same day can be huge. And then anabolic medications. And so the one that is FDA approved to be used in the United States, although there's still, I think, in some clinical trials, is ramucirumab. And what that medication is, it's an anti-sclerostin antibody. So sclerostin in general is a big inhibitor of bone formation, just on how bones are formed. And so if you provide an anti-sclerostin antibody, then that allows bones to form. So rather than using a bisphosphonate, which is anti-resorptive, which prevents bone from breaking down, I think where the future is going to hold even better for some of our OI patients is giving them a more of just this catabolic bone formation type medication. I think is going to be huge. So more to come with that. And I'm hoping that in your country, you're starting to see some of these medicines too. I can't wait to ask you about that. But I think this is where the future for our medications are going to be changing. Right now, we only have one good medicine, and there's going to be more coming down the pipeline very soon. Some more looking at non-unions. So this was a study that came out of JBJS in 2015. Again, looking at supplemental plate fixation to help with non-unions. And you can see that they did a beautiful job here at realigning this femur. And again, that plate there is quite different than the size that you've seen in some of my pictures. But I think the key there is making sure you take it out because it's just too big of a plate, I think, long term. And I know in their study, they did have some of these screw hole fractures that happened post-op once they took the screws out, but they were treated all non-operatively. But this, again, is a great solution if you have a problem like you're seeing in that picture A. I also want you guys to see the severe protrusio so that you can see in that picture, sometimes the protrusio can be so bad that you can't even get a rod into the trochanter or the piriformis because you can't access it. Because of the protrusio. So even that one, you can see how much worse the protrusio gets over time there. But that's a different problem. This is from one of my colleagues, Dr. Franzone. This is, again, a little bit more typical for how we approach it here in the States. But with non-unions, again, sometimes making the rod not too big, not too small, we don't know what that size is yet, but adding supplemental plate fixation as you're seeing here, and then oftentimes they're adding allograft and cerclaging that in as well. For some reason, OI, the ability to incorporate allograft is quite impressive compared to other diseases, and so we use it quite frequently as additional supplementation. I do know some of my surgeon colleagues in France that use just allograft and cerclage that in and don't use plates at all. So again, lots of different solutions to try to help with these problems, but I definitely don't have the answers, but just really want you to stimulate to think about some of these problems. So revisions are a really big problem as well. And again, at least for me, the goal is to try to minimize the amount of revisions. So if you look at this picture on the left, this rod is too big. If you look, you don't see any bone medial or laterally around the rod. And so you want to be cognizant of that. So in some of our conditions, we want the biggest rod we can to get the most rigid fixation as possible. But in OI, we know that's not really the case. If you put in a rod that's too big for the bone will disappear. Versus the picture on the right looks like one of my patients where when the rod's too small, eventually it'll bend. And again, a different problem. And we're still trying to figure out, well, what's the right size? And I wish I had that answer, but I really don't. When to revise? If you're using a telescoping rod, whether you do the Fossey-Duval rods that we're seeing here, or if you're putting in intramedullary rods from proximal and distal and they're overlapping in that sense, when do you start revising that? And I don't really know. And we're doing some biomechanical research on that right now, trying to figure out that optimal time. Because again, revisions are challenging for the surgeon as well as the patient and family. So we want to try to minimize that. So I would encourage you to really look at the rod size and just make sure it's not too big. And to me, when I'm reaming, I never want the reamer to be really hard to pass. If I'm Dr. Fossier has taught us to never replace bone with metal. So we don't want to ream it until there's no outer cortex at all. So it should pass pretty easily for me. And then just my overall gestalt without any signs is about 50% the canal. So that's usually what I'm aiming for. This is a case where obviously the rod is pretty small. So this is one of my patients. She had her rods put in by a very reputable surgeon when she was 13 months of age. And she had no problem. She was well treated. And we had been watching her year after year, but you could see to revise that rod would have been really hard. And so here's a case where the rod was just too darn small for her and it couldn't protect her. So she tripped and fell. And then I revised her, as you're seeing over here on the right. Excuse me. And I said, well, your left femur looks just like this. We should probably get to your left femur because if you fall, again, it's not going to be big enough for you to get this, for you to be able to protect the rod. But unfortunately, she fell 4 months later and then did, unfortunately, the same darn thing. So then we had to revise her. But again, as far as the rod size, I believe that the ones that she had in were 3.2 millimeter diameter, and I upsized her to 4.8. So again, we can get them to heal. But again, obviously the goal is to try to get to this before she catastrophically fails like this. I wish I could have gotten to her a little bit sooner, but this was only 4 months later. Here's another one. This is one of my patients. He has type 4 osteogenesis imperfecta. He is Vietnamese, and the only reason why I bring that up is that I don't speak Vietnamese very well. I speak Spanish just fine, but there's definitely a language barrier despite the interpreters. He's on bisphosphonates very regularly, and he comes in with this subacute fracture. And so my question was, gosh, well, what do I do? He doesn't have any symptoms anymore. Do I revise it? Do I not? Maybe I made the mistake, but I decided to leave him alone. He right now has absolutely no symptoms. He has the leg length difference, which is another research project I've been working on. But it's hard for me to take all of this out to revise it on someone who has no symptoms at all. And again, this might come back to haunt me later. I think the rod now looks a little undersized for him. I like the one on the right much better. It's a much bigger rod. But again, these are the things that are hard of what's the risk of surgery versus the risk of leaving this alone. And I don't have all the answers. You probably thought I was going to revise this one, but this one I left alone. Although I would anticipate that in years to come, I'll probably have to revise this at some point. So this is probably one of the biggest challenges we have right now is acetabular protrusio. It can be really painful. And once the protrusio becomes severe enough, it really puts people at risk, high risk for femoral neck fracture because the femoral neck is now impinging on the edge of the acetabulum. It increases the risk for need for total hip arthroplasty. And how are you going to put a total hip in someone who has no bone stock? I'm going to show you some extreme examples of what protrusio can look like. And then the biggest challenges that we're seeing long-term are more with constipation and difficulty with urination. So this came from Dr. Franzone, but look at the protrusio here. And I don't know if you can see it. This patient was having hip pain, and there's a femoral neck fracture you're seeing. That's basicervical. And so I believe there's some CT scans that you're seeing here for this. But again, it's really hard to adduct the leg to try to even fix this hip. Well, look at this bone stock and look at the protrusio. That picture on the upper right is trying to show you the bowel and just how very little room there is for the bowel to expand. So again, constipation is a huge issue. If it were a woman of childbearing age, there's no way that a woman could bear a child with protrusio like this. And this is just one picture from one of my colleagues, but I have very similar pictures in other patients. But again, you can't do a total hip in this. I don't know of a great way to reconstruct this, but these are really bad problems that we're seeing time and time again, now that we're getting much better at some of the other issues. So, back to this one here. So again, if you're seeing the CT scan on the right, this is what femoral necks look like that are more subtle. So you're, especially on that coronal view, you're seeing almost that buckling and that inferior collapse. Very, very classic for this femoral neck fracture. And then you'll see it on the axial view as well. Luckily, when the rods are in, starting in the piriformis fossa, you have all that room anteriorly to fix them. And there's lots of different constructs you can use to try to fix it. What a lot of us are doing now, the CT scan is also helpful at getting a pre-op plan to know what size screw you can use. But this looks like a 4mm cannulated screw with a washer. And then we leave the wire in the screw and then bend that over and then cerclage that with some allograft. I don't think we have the data yet to show that this is the best way to do it per se, but this works pretty well. And that luckily you don't have to revise the rod, which again, there'd be almost no way to get the rod out at this point because the protrusio is so severe. But hopefully, again, you've seen enough femoral necks just on this presentation to know what to look for. And then this is at least similar to me, the preferred way for us to treat it if you can. So more about protrusio. This is Dr. Raggio's group out in HSS in New York City. They looked at risk factors for acetabular protrusio. And even though I showed you some more severe examples, what they really found was that all types were at risk and that it can be progressive. And I believe in their study, they found that the type 4s had a much higher risk compared to some of the other types. I've seen it in certainly all types, 1, 3s, and 4s. Obviously, the other types are just much more rare that I don't have a lot of them in my practice to be able to say definitively who's at risk. When it comes to treatments for it, again, we can't really treat the bony part, but Dr. Wallace, who's now in Phoenix, reported on the use of ostomies for these patients. And even though young children and young adults may not like the idea of an ostomy, it can really substantially improve the quality of life. Again, you can see just how severe these protrusios can get. And unfortunately, we just don't have good bony solutions at this point to try to help them. So again, in summary, I think we're doing a much better job at with the moderate to severe OIs at allowing children to live and have this near normal life expectancy. And I really think it's this multidisciplinary approach of early treatments, bisphosphonates as soon as the genetic diagnosis is made, and then really early on, it's the therapies, and then the surgeries, and then continued therapies. And then again, the concerns, at least that we're seeing in the orthopedic world, are these revisions and non-unions, and at least here in the States, who's going to take care of these adults? Because we don't really have a lot of surgeons that know, at least for adults, what to do. Orthopedic research, when it comes to what we're doing, to me, like I want to know what's the ideal rod diameter to begin with. We're also doing some non-union research. That's a big project that we're working on internationally. And I think we have to try to come up with some type of treatment and solution for some of this protrusio before it gets too severe. So thank you for your attention. I want to show us some more pictures from camp because these kids are awesome, and I'm certainly happy to answer any questions that you have. I'm going to end this and stop sharing my screen.
Yeah, thank you, Jill, for a wonderful overview of the treatment. And you rightly pointed out that in last 2 decades, the management has really improved and reduced the complication rate. I would like to ask you a simple question, like when we carry out rodding, how do you control the rotation?
I don't. So what I've learned in the last 14, 15 years of looking at this is that even when I control the rotation, I mean, you could certainly do it with a plate. Like, so post-op, the younger kids, I have them usually in like a one-leg spica cast to try to have at least hold it there for the early healing. And then all of them externally rotate over time. And that's just because of the weak gluteal muscles that they have. So even if I focus really, really hard on getting their patella forward post-op, they all turn out eventually anyway, especially the ones that are weaker. And then usually when the rod's in enough, I don't find that they rotate all that much. There's probably maybe only one or two over the years that they've clearly have rotated since the time of their initial injury or surgery, excuse me. But when they're younger, I do some very lightweight spica casts. When they're older, sometimes I'll brace them, but I just try to limit them from doing active rotation, and I haven't had that to be a really major problem, even though it's a very good question.
Okay, we have a few questions in the chat. I would read for you. The question is from Jonathan. How do you think bisphosphonate act on unmineralized osteoid in type 6 OI?
Ooh, I gotta learn what my type 6 is again. I don't remember if that's one of the, it's not the LEPs, those are the ones, that's the 7 and the 8. So I don't have a type 6 in my practice. But if it's one of those higher risk non-union ones, they're hard. Get to my slide here. But again, I think OI, the bisphosphonates, what we know is they are definitely not the best medication at all. And for a while, what we said, it was the best that we had. Oh, that type. Ooh. I've seen some of those. We have an OI surgeon meeting here quarterly in the States, and I've seen some of those non-union ones too. Again, even the 7s and 8s, and then the 15, that's the WNT1 classification or WNT1 mutation. Bisphosphonates do not work as well at all. And again, I would say, as of still even right now, it's the only medicine we really have, and it affects other things that are good, but I don't really think it works pretty well in that type 6. So hopefully, I think the sclerostin antibodies are pretty promising, and then there's some other different, certainly, pathways that we're trying to look at. So I don't know if that really answered the question, so I apologize.
Okay, then the question is about the non-union in humerus. Other than the reasons mentioned by you, do you think that hypotonia due to collagen issue or non-weight bearing, unlike lower limb, could be the possible reasons?
Yeah, I mean, they get the hypotonia and hyperlaxity, and it all kind of goes together. Sometimes it's helpful. But I think with those, what I find with the OI, again, just as I said in the beginning, the more I'm doing it, the more questions I have than answers. But I feel you have like a very finite window. And so again, when I first started, we always thought we should rod kids in their lower extremities at age 5 or 6. And I'd say myself and a lot of my colleagues that do a lot of this, we're starting to rod younger. Even though the revisions are a bit higher, it's just easier. The canal is still there. And I still think the same thing for the humeri is if you wait too long, the canal goes away. And I really think that increases your chances of non-union. So the one that I showed you, my colleague did, where she revised it 3 or 4 times, and I look at that, just, gosh, this person's just too old and it's just too far gone, where again, you may cause more harm than good. I don't think it's the tone and the laxity. I still think it's that bone stock there. It's really hard to get really rigid fixation, and you want to get the elbow moving. And then what happens is, rather than the elbow moving, the fracture moves. And so that's what we see. And then the bone, and then if you make it too rigid, sometimes then the bone disappears. So again, we really don't have a great solution for that distal humerus. But I would advocate, if you're seeing deformities being sometimes more aggressive when they're younger, when they just have better capacity to heal.
Okay, we will take a question from Thomas, and then we will take a chat question. Yeah, Thomas, please.
Yeah, Jill, very nice illuminating talk about OI. Very reassuring to know that children in Atlanta also face problems of access to healthcare. And nice to know that yoga, which is our main thing here, is entering mainstream thing in the US. My question is about, my question is about your protocol. So how long do you give bisphosphonates? Do you do a DEXA? Do you do a bone mineral density? When do you choose to rod them? Do you give them a drug holiday and then come back? And those kind of things in your protocol.
Sure. So again, what I do is probably pretty different than some other centers around the country when it comes to the rodding and bisphosphonates. I'm really blessed to have an amazing endocrinologist. So she does manage all the bisphosphonates and the DEXA scans. But in general, for the bone density test scans, under the age of 5, we don't have Z-score norms. So I think she starts doing DEXAs at the age of 3 just to see the total bone mineral and then follows that over time. And then at the age of 5, then certainly we can see the Z-scores. So we usually start DEXAs at around the age of 3. Before then, I think just your lateral TL spine can be helpful to look for compression fractures. And we'll follow that. And I know she'll titrate her medications based on that. For timing of rods, Dr. Fossier taught us to start rodding considering when they pull to stand. And I think that holds true. But there's some of my patients where I find that if I don't rod them, they're not going to stand because they're so severe. So if they're having just multiple, the youngest I ever rodded was 13 months. She didn't start walking until 4.5. But the reason why I rodded her was because she would just kick her leg and play and break her femur. And there was nothing else I could do. And then once I rodded her, then she was able to gain the function, decrease her fractures, and so on and so forth. And obviously she's a pretty severe OI to walk that late. So, but in general, it ends up like 18 to 24 months tends to be that sweet spot, at least for me, of that's when a lot of them are pulling up to stand anyway. At least for me, I think in parts of India, it's probably hot all the time, but people with OI tend to be are hypermetabolic, and so they're sweaty. And for me as a limb lengthening surgeon, my summers are super busy doing lengthenings. So actually usually push all their surgeries off from October through February when it's colder out, when they're not swimming in pools. And that works out well. And then as far as the timing of bisphosphonates, the half-life of the bisphosphonates 9 years. So I cannot, does not make sense to me to give them a holiday. Because to me, for the severe ones, the risk of not giving it is greater than the risk of giving it. And I just don't see the amount of non-unions. I think the principles like what we do in lengthening, low energy osteotomies, cooling the drill bit when I use a drill bit to break the bone, keeping it cool. For a tibia, I use a rongeur, so it's as low energy as you can imagine. And I don't really see a ton of non-unions from it. So again, the kids are more scared of the IVs, which are hard to put in. So I give bisphosphonates the day after surgery. When they're due for it. So obviously when they're getting, I think that's every 10 weeks when they're younger, every 2 months when they get a little bit, every 2 months and every 10 weeks and every 3 months and every 4 months for imagery is pretty typical.
So the fixation that we use in India through the big centers, Manipal where Hitesh comes from, Dr. Benjamin Joseph and us, we use the rush rod, the good old rush rod, because of the cost issues and because we don't get the original Facet Duval rods in India. There are imitations, but there are problems with those imitations as well. So we use the good old rush rods, keep revising it. And I think Dr. Benjamin Joseph has published about rush rodding from both ends, like you see in the femur from the bottom and from the top, so that the overlap causes tides over the growth for that amount of time. A double rush rodding technique,
Yeah, I've seen many x-rays and I've seen that, and I think that's a great solution. Again, I think it's a mathematical model, but I think the number is about 50%. So when you start to get less than 50% overlap, that's when they start to bend. But wouldn't it be great to be able to pull a rush rod out and just put a new longer one in without breaking the bone again? So those are the questions that I want to be able to answer to not only minimize revisions, but when we do the revisions to make it easier on the families.
It's also humbling to note that we are not the what do you say, the people who do the most, but you said pain is a big issue and psychology with your question as the biggest issue among this OI. So it's very humbling to note that we surgeons are not the real people who matter in OI.
Exactly.
Yeah.
So then there is a question about any experience of using romosozumab in type 5 or 6. I think for type 6, you have a very limited experience. So what
Yeah.
about type 5?
The clinical trials aren't allowing it. So if you look at the clinical trials, they only want to look at type 1 collagen mutations. So again, I only have one type 5 in my practice. He's on bisphosphonates. So that's the hard part. And hopefully we can get those studies down the line at looking at the type 5s. And then again, some of these other recessive types that are non-collagen mutations. But unfortunately, all those clinical trials, because they want to be shown to be safe and efficacious, they're only limiting it to collagen 1 mutations. Usually it's types 1 through 4, unfortunately. So I don't know. I can't think of any clinical trial where they've looked at type 5 because of that, unfortunately.
Then there is a question that for the protrusio, have you tried excision of the femoral head? That's the Girdlestone procedure to relieve pain, because we don't have a good solution for that.
That's a great question. I personally have not done that. I guess it depends on where the pain's coming from. So we obviously won't change the constipation issue or the urination issue. I have not done anything surgically for protrusio other than, at least for me, I refer them to pain management. That's an interesting thought. Or similar to what they do in cerebral palsy, almost like the troch sparing, where they're using that muscle interposition to try to help to put some kind of soft tissue in between. I don't know. That's an interesting idea. I have not done it.
Okay. And then there is a question that do you think that bisphosphonate increase the risk of spinal canal stenosis?
Not that I know of. Again, it's definitely not the best drug that's out there, but we have not seen specifically stenosis because of bisphosphonates per se. And I think that we know that if the bones are healthier, it'll decrease the chances for scoliosis to a certain degree. Scoliosis, again, that is an enigma to me. I've seen the most severe types that are ambulatory not get scoliosis, and I've seen the most severe types that are ambulatory get scoliosis, and everything else in between. But I don't think of specifically increased risk for stenosis because of the bisphosphonates.
Okay. Then regarding the bisphosphonate, which is your preferred molecule?
Oh, pimidronate versus zoledronate?
Yeah.
I guess is my question. Yeah. So again, it's really going to be up. It goes back to that axis of care. And I personally like pimidronate better. Like sometimes I can feel surgically the difference between the two. Because the Zol to me, especially with a rongeur on a tibia, it's so brittle, it just cracks. And the PAM to me doesn't feel that way. And that is so unscientific, but I can usually feel the difference. However, the dosing rate is so much less with the Zol. Again, when we think about access to care and the traumas from the IVs for the families, the Zol and the fusion time too is so much less. It's 1 hour infusion versus 4 hours. And so we're starting to make that shift, going from more pimidronate to zoledronate. Our families tend to be very opinionated, as I'm sure yours can be too. Some families do not want to switch over, and some are really happy with the switch over to Zol just for the convenience. But I personally like pimidronate a little bit better, but I think just as many programs are doing, many people are switching to Zol just because there's really no scientific proof that one is better than the other.
So,
and what about the oral bisphosphonate? Because alendronate or the risodronate, what about using them? Because that reduces the cost to great extent.
Absolutely. It definitely reduces the cost. The problem is, and I should have the studies, but there's some pretty good studies that show it just doesn't have the same efficacy as the IV. However, that being said, is it better than nothing? The answer is yes. So if it's a cost issue, I do think that the oral is probably better than nothing, but we know that the IV tends to work better than the oral.
Dhiren, can I just weigh in on this? Because David Sillence visited our center, and
please.
the endocrinologist called the big man, and he said that pamidronate for children is better and increases the bone mineral density according to him, whereas zoledronate increases the vertebral column and the spinal bone mineral density is better for adults. That's what he said. And he said oral forms are not as good. That's what David Sillence said in the meeting here in Vellore. Yeah.
Yeah, I really like Pamigenate better, personally, but again, it's just hard because of access to care.
Yeah, and we have to admit the child for 3 days, look at calcium and monitor the child for allergic reactions, fever. So in India, it's a problem.
Yeah,
but it's probably the best.
No, but Jill, do you do the same thing like the preoperative calcium, phosphorus, and then again after treatment you monitor those levels, or you just for the first time you check all these things and for the subsequent treatment you don't carry out all those tests? What is your preference or protocol?
Right. So what the endocrine team does now, again, they do it so good I barely watch them anymore. I believe they check the labs preoperatively and they're just all getting their calcium and calcium to go home with. So they're not checking calciums anymore afterwards, but they go home with 3 days of the calcium and D. And from my understanding, they haven't had any problems as long as the families are educated about getting the calcium afterwards. But obviously the first infusion is very different. Those are all inpatient, watching them very closely just because of the hypocalcemia risk is so profound. But afterwards, once we know they can tolerate it, outpatient, I think they check their calciums but I can't promise you that, but I know they do not check labs post-infusion anymore. They don't check labs.
Okay, Jill, thank you very much for a wonderful exposition about the topic and the interaction which we had following your talk. So I'm sure that this is going to be of great help to our fellows. So thank you very much for sparing your time from your busy schedule. I know that how busy you are, but still you choose to share your knowledge with us. Thank you.
Yeah, thank you, Jill. It was a pleasure. Thank you.
Likewise, take care.
Bye-bye.